So now this is our new, very interesting, and perhaps one of the most longest lecture series. It will be longest because there are too many infections out there, and even if we start covering the basic or the major infectious diseases, it's a very long list. So this lecture series will be maybe comprising of 8 or 10 lectures, or wherever fate leads us. But basically, it's an extremely important lecture series. So it's and what's happening? Somebody is maybe messing with screen share. What is happening? My screen
I
got
will
red
clean that up for
for
you.
a few
I will clean that up
seconds.
for you.
Okay. Infectious disease part one. So basically, it's part one is because I am discussing HIV or AIDS. But as I was preparing this presentation, so I came to know that it will be extreme injustice with this much diverse and with this much important topic to just hop on from every concept and just try to squeeze it in within 45 to 50 minutes, as I was unable to squeeze it in within 55 to 40 minutes. So I had to divide this HIV class further into two parts, part A and part B. So basically, today is understanding the transmission, prevention, and control of HIV/AIDS, part A, and then we will have to discuss its part B, as well, as I was unable to squeeze all the content, all the knowledge that I wanted to deliver to my students within a single class. So we are gonna start. So basically, it's introduction, basic definitions, etiology and epidemiology, HIV infection, types of HIV virus, what's happening, pathophysiology of HIV infection and AIDS, clinical signs, symptoms of AIDS, and then these points as 7, 8, and 9. These we will discuss in part B, basically. Uh, our second class, diagnosing a patient with HIV/AIDS. How do you diagnose a patient with HIV/AIDS? Then we will discuss in detail. I will go in detail about the prevention strategies from getting HIV infection, and then we will discuss in detail about the management and the control of a patient with HIV and AIDS. So, introduction. HIV remains a global public health issue, having claimed an estimated 42.3 million lives to date. Transmission is ongoing in all countries globally. There are an estimated 39.9 million people living with HIV at the end of 2003. 65% of whom are in the WHO African region. So basically, majority of AIDS patients in today's world are from Africa. In 2023, an estimated 630,000 people died from HIV-related causes, and an estimated 1.3 million people acquired HIV. There is no cure for HIV infection. However, with access to effective HIV prevention, diagnosis, treatment, and care, including for opportunistic infections. HIV infection has become a manageable chronic health condition, enabling people living with HIV to lead long and healthy lives. WHO, the Global Fund, and UNAIDS all have global HIV strategies that are aligned with SDG target of 3.3 of ending the HIV epidemic by 2030. So, in order to understand the basic concepts of what we are going to discuss, because infectious diseases is a vast and a completely different word from what we were discussing in our last lecture series. So basic definitions. HIV. What is HIV? So HIV stands for human immunodeficiency virus, which is the virus that causes HIV infection. HIV attacks immune system of the body of the patient, causing severe damage to the immune system of the patient. And then we must know what is AIDS. AIDS stands for acquired immunodeficiency syndrome. So AIDS is basically the last stage of HIV infection. If you contract a virus through some host, then first acute phase, then chronic phase, and then the last phase of that infection comprises AIDS. So AIDS stands for acquired immunodeficiency syndrome. AIDS is the most advanced stage of HIV infection. HIV attacks and destroys the infection fighting CD4 cells, which are CD4 T lymphocytes of the immune system. And the loss of CD4 cells makes it difficult for the body to fight off infection, illnesses, and certain cancers. So this is acquired immunodeficiency syndrome. After infection with HIV, uh, there comes a condition when our immune system is so much damaged, these CD4 helper T lymphocytes are so much damaged that our immune system stops of normal infectious agents. We do not cause diseases if the patient is healthy. For example, tuberculosis, cryptosporidium, and many other diseases. So basic definitions. T lymphocytes, also known as T cells, are a type of white blood cells that plays a crucial role in the immune system. They are responsible for cell-mediated immunity, directly attacking and destroying infected or cancerous cell, and also help regulate the overall immune response. So this is basically, I have added a schematic diagram. So there is a blood stem cell, pluripotent hematopoietic progenitor stem cell, which is also called blood stem cell in layman language. The blood stem cell then produces two types of stem cells further. One is lymphoid stem cell and the other is myeloid stem cell. And then the myeloid stem cell for differentiates into many other types of cells. For example, if it converts into myeloblasts, then myeloblasts give rise to basophils, eosinophils, or neutrophils, etc. Then myeloid stem cell also creates a cell which is called megakaryocyte, which then creates platelets. And then myeloid stem cells also create many cells which eventually end up in RBCs or red blood cells. Then there is a lymphoid stem cell. A lymphoid stem cell produces lymphoblasts, which are comprising of B lymphocytes, T lymphocytes, and natural killer cells. So basically, these B lymphocytes and T lymphocytes and natural killer cells, along with granulocytes, which are eosinophils, neutrophils, and basophils, are white blood cells. And T lymphocytes are extremely important because they are the one, these are the cells which directly attack many of the viruses and fungi or mycobacterium, etc. And they attack as they are cytotoxic cells and they protect us from many advanced illnesses. So, among T lymphocytes, what is a helper T lymphocyte? So, helper T lymphocyte is a CD4 positive. So, CD4 positive is basically surface protein surface protein marker, which is used by histopathologists to identify which is a helper T lymphocyte. So it's basically a surface protein on the surface of helper T lymphocyte that is CD4 positive. So produce these helper T lymphocytes produce cytokines that influence other immune cells, coordinating the overall immune response. As the name states, these cells activate cytotoxic T cells and B lymphocytes. So cytotoxic T cells are CD8 positive cytotoxic T lymphocytes are killer T lymphocytes. So cytotoxic T lymphocytes are CD8 positive. It's another surface protein which is used to identify the cytotoxic T cells. The helper T lymphocytes activate cytotoxic T cells and then cytotoxic T cells attacking the foreign infectious agent. So basically, helper T lymphocyte is the major coordinator. It also coordinates antibody production against any which is damaging our body. So helper T lymphocytes not only help us produce antibodies, Adia, बाजी को बुलाना. And it not only produce B lymphocyte or not only produce antibodies, but it also activates cytotoxic T cells. There are some other viruses as well called retroviruses. Any of a family of RNA virus that have an enzyme called reverse transcriptase capable of making a complementary DNA copy of the viral RNA, which then is integrated into a host cell's DNA. The family includes a number of significant pathogens, typically causing tumors or affecting the functions of the immune system. HIV HIV is also an example of retrovirus. HIV is also an example of retrovirus. So retrovirus are the viruses which have reverse transcriptase. So this reverse transcriptase is a remarkable enzyme. With the help of this enzyme, many viruses create the DNA copy of their in host cell. So basically, a retrovirus is a class of viruses which have this enzyme called reverse transcriptase. That is why these are called retroviruses. Understanding HIV infections and AIDS. In this section, we will discuss all the brief clinical details and understanding of HIV infection and AIDS. So, what is etiology of HIV infection? Factors that can contribute to a person becoming infected with HIV include any of the following. So HIV is part of the Retroviridae family in the lentivirus genus. The virus mainly targets CD4 lymphocytes, helper T cells, leading to extreme immune suppression with a continuous loss of cells. This suppression weakens the immune system and causes many clinical symptoms. We already discussed it. Then, how this virus is transmitted to other from one person to another person. So the most widespread and the most important pathway is the sexual transmission. Sexual transmissions account for the bulk of new infections in the United States. Uh, receptive anal intercourse is the highest risk sexual practice for HIV transmission. The risk of receptive and insertive vaginal intercourse is 8 and 4 per 10,000 exposures respectively. So basically, sexual transmission is one of the most important transmission pathway for the bulk of new infections in the United States and worldwide. Receptive anal and vaginal intercourse, especially receptive anal intercourse, if you are the receiver of anal intercourse, is the highest risk factor of sexual transmission, highest risk factor for sexual transmission of HIV. So the risk of receptive and insertive vaginal intercourse is 8 and 4 per 10,000 exposures respectively. So in sexual transmission, the major causes are having unprotected sex, anal or vaginal sex without a condom with a person secreting virus in their body fluids is a major risk factor, with the receptive anal intercourse carrying the highest risk. If you are having multiple partners, if you are promiscuous in your sexuality, then individuals with multiple sexual partners have an increased risk of exposure to HIV, because you never know which person is carrying HIV and which person is not. And other STIs are basically sexually transmitted infections. So STIs or STDs are sexually transmitted diseases or sexually transmitted infections. So other STIs having other sexually transmitted infections like syphilis, herpes, chlamydia, gonorrhea, or bacterial vaginosis can also increase the risk of HIV transmission. Then blood-borne transmission is the second most common and most important factor. Injection drug use currently represents the most significant risk of HIV transmission via the blood-borne route, with an estimated 63 infections for every 10,000 exposures from an infected source. So basically, it is the most important pathway if you are talking about blood-borne route of infection spread. Then injection drug use, because many of the people who are IV drug abusers or injection drug abusers, they do not care. They are using injections from everywhere. They do not care about single use injection. They are lying on streets using injections for 200 times and using injections in multiple people. So they are basically exposing themselves to a variety of viruses, including HIV as well. So sharing needles, syringes, or both injection drug injection equipment can directly expose individuals to HIV infected blood of any person who is in the community of those people who are sharing needles among each other. Then contaminated equipment, accidental exposure to HIV positive blood through needle sticks or other contaminated equipment can also lead to infection. And the healthcare system has nearly eliminated blood transfusion transmission of HIV. So basically, originally when there was not that much research done in healthcare settings, so the blood transfusions were also leading to the transmission of HIV infections among the donors and recipients. So basically, if the recipient received 1 pint of blood from a donor who was not tested with HIV, then definitely that recipient was about to get HIV. So the healthcare system now has nearly eliminated blood transfusion transmission of HIV by effectively screening donors and testing all blood products. Otherwise, for every 10,000 infected blood transfusions, HIV will be transmitted to approximately 9,250 people recipients. Now imagine the risk factor for blood-borne transmissions with injection use. It was 63 infections for every 10,000 exposures. Just 63 infections for every 10,000 exposure from an infected source. And with sexual transmission through anal or vaginal intercourse, it was 8 and 4 per 10,000 exposures with an infected source. But if you receive the blood of an infected individual, the chances are that 9,250 people will surely get an infection of HIV, will surely get an infection with HIV. So there is no chance of running away if you are receiving a blood of a person who is not testing, who is positive for HIV and the screening is not done. Then the third most important risk factor is maternal infant transmission. Maternal infant transmission means mother to child, mother to newborn transmission. Without treatment, the risk of vertical transmission from mother to infant is approximately 20 to 30%, as the virus is secreted in all bodily fluids, including breast milk and vaginal fluids. So, during pregnancy, HIV can be transmitted from a mother to her baby through the placenta. Directly, blood can mix. Basically, blood does not get mixed. There is a membrane, so the plasma and the proteins transfer here, and along with these proteins and plasma transfer, some of the viruses also cross the placental membrane barrier and go to the child's blood. During childbirth, definitely, as the child crosses through the birth canal, so there are the virus is present in vaginal secretions. So if when the child is passing through birth canal, there is vagina of the mother, and the child gets exposed to virus present in the vaginal secretions of the mother. Then HIV can be transmitted in the bodily fluids, including breast milk. So breastfeeding also results in transmission of the virus through breast milk. That is why if a mother is HIV positive, the breastfeeding is contraindicated until and unless it is proven that mother is seronegative or the mother's viremia is controlled to the optimal levels. Viremia means the presence of viruses in the blood. Anything ending in emia means in the blood. For example, anemia means low HB of the blood. And similarly, viremia or bacteremia means presence of bacteria in the blood, presence of viruses in the blood. So number four is high risk behaviors. So high risk behaviors such as substance abuse can impair judgment. For example, if you are a cocaine user, if you're not an injection drug user, but you are a substance abuser, you use cocaine, you use methamphetamine, you use heroin, or you are a drug addict basically. If you are a drug addict, apart from being an injection drug abuser, if you sniff, inhale, or use it with cigarettes or whatever the way you do it, if you are doing substance abuse, it can impair your judgment and eventually increase risky behaviors in your life, potentially leading to unprotected sex or needle sharing. So this is also an etiology of HIV, the high risk behaviors. So basically, if you are a drug abuser, apart from being an injection drug abuser, if you are a drug abuser in general, if you are an alcoholic, if you are a cocaine user, if you are a heroin addict, if you are a meth head or methamphetamine user, ice, which is called ice in layman language, so if you are a substance abuser, it can impair your judgment with low self-esteem, with no self-worth, with no judgment, with no thinking about the consequences of your immoral actions. And this increases risky behaviors, potentially leading to unprotected sex, promiscuous behaviors, and needle sharing as well. Now, the epidemiology of HIV infection. So, HIV is a significant public health issue worldwide. HIV-1 causes most infections with HIV-2 account. So, there are two types of HIV, HIV-1 and HIV-2. We will discuss it later on. HIV-1 causes most infections, with HIV-2 accounting for only 1 to 2 million infections worldwide. So basically, worldwide, HIV-1 causes most infections. The prevalence of HIV-2 exceeds 1% of infections only in West Africa, although infections occur less commonly on all continents, particularly in cases with colonial or other ties to the area. According to the WHO, by 2023, HIV/AIDS had killed approximately 40 million people. According to the WHO HIV fact sheet, there were 39 million patients with HIV at the end of 2022, with majority like for 25.6 million living in sub-Saharan Africa. Yeah, Africa is the hub of HIV infections worldwide at present. In 2022, 1.3 million new cases of HIV were reported worldwide, with 630 deaths, as already discussed in introduction part, 630,000 deaths related to HIV in the same year. UNAIDS and WHO identified five key populations who are disproportionately affected by HIV and warrant specific care and support to reduce global transmission. So there are five key population areas. Men who have sex with men, they are the most problematic for HIV infections because they are the cause of increase of HIV infections worldwide. So basically, gay men are the most problematic for the world related to HIV infections. Then sex workers, obviously. Then people in prisons and other closed settings. Then injection drug abusers, people who inject drugs, and then transgenders because transgenders are also promiscuous. They have no concept of fidelity. So basically, the transgender community, people who are injection drug abusers, then gay men are the most problematic, then overall sex workers, and then gender diverse people. So basically, all the people who have gender phorias and mental health issues related with their gender and mentally abnormal related with their gender, then these people are at high risk of getting HIV infections due to their promiscuous behaviors. In the United States in 2021, 71% of all new infections were in men who have sex with men. Imagine. To 70% of all new infections among all the subclasses, no maternal or infant, no injection drug abusers, 70% of all new infections were in men who have sex with men, whereas only 22% occur through heterosexual contact. Although some countries report an increase in new infections, the overall global trend in HIV incidence has decreased. In particular, significant gains prevent and treat HIV in Eastern and Southern Africa, where the virus is most prevalent. From 2010 to 2022, 57% fewer new infections and 58% fewer AIDS-related deaths occur in the region. So basically, overall in Africa, yeah, especially in Southern Africa or Sub-Saharan Africa, infection rate is decreasing and AIDS related deaths are also decreasing due to the international community's intervention. So this is the share of population living with HIV. So estimated share of the population aged 15 to 49 living with HIV. So some of the countries which are in maroon color or deep red or orange color, they share the extreme burden or the most burdenized countries with HIV infections. For example, the Southern Africa or Sub-Saharan Africa accounts for 5%, 10%, or 20% of the cases worldwide. And the countries which are pasted in yellow color or cream color have infections around 0 to 0.1%, and then a bit darker shade are the countries which have infections around 0.5% to 1%. But in countries where there are more than 2% or 5% or 10%, 20%, these are the countries which are present mostly in Africa. So types of human immunodeficiency virus, as we already know, there are two major types of HIV, namely the HIV-1 and HIV-2. HIV-1 is the most common and most pathogenic strain of the virus. As of 2022, approximately 1.3 million such infections occur annually. Scientists divide HIV-1 into a major group, Group M, and two or more minor groups, namely Groups N, O, and possibly Group B, as these are the minor details. And if we were studying virology in general, I would have gone into the details of what these subgroups or major groups called M, N, O, and P mean. But as we are not discussing, as the focus of our lecture is not on the virology and not on the virus itself, so we will not go into extreme details like discussing subgroups and subtypes as well. So for the sake of general knowledge, there are some important subgroups called major groups of the HIV-1. Among them, Group M is the most common, and Group M causes most infections worldwide. Majority of infections by HIV-1 are caused by Group M of HIV-1 viruses. This major HIV strain, which is a source of pre-1960 pandemic viruses, originated in the 1920s in Leopoldville, the Belgian Congo, today known as Kinshasa, which is now the capital of Democratic Republic of Congo. So basically, there is a sad history of Africa, the colonial past of Africa. Africa was colonized by European powers, by colonial powers, and Africa was divided, and slavery was common in Africa. So the Belgian Congo was the main pre 1960 source of pre 1960 pandemic because of the poor hygienic conditions, poor public health uh, control and poor management and colonial masters not caring about the general population. So many of the people died because of these unknown illnesses. At that time, HIV was an unknown, mysterious illness. Nobody knew why these people are dying, why these people are dying of um, bizarre cancers, why these people are having more infections with TB, why these people are having very destroyed immune systems, but these people died in bulk in those parts of Africa. Apart from DRC, there are many other countries in sub-Saharan Africa as well who were colonized, and then these diseases spread in those countries because the fabric of the normalcy or the GDP of those countries was robbed. The health of those countries were robbed. They were enslaved. Their healths were destroyed. Their social fabric was destroyed. Their countries were devastated. All of the rich minerals, all of the rich resources, everything was robbed and shipped to Europe or shipped to other colonial uh, powers, majority Germans, Portuguese empires, the French, the British devastated the Africa more than anyone. So British people devastated the Africa as well as Indian subcontinent more than anyone. So all of these diseases were spread in Africa in pre-1960s colonial era. So comparison of HIV species, HIV-1 is a lentivirus, and its virulence is high, its infectivity is high, its global prevalence is global, and its inferred origin is a common chimpanzee. Chimpanzee is a monkey. And HIV-2 is also a lentivirus, and its virulence is low, its infectivity low, its prevalence is only in West Africa, and its inferred origin is Sooty Mangabe, which is also a species of a monkey. HIV-2 is mostly found in Africa and therefore less recognized elsewhere in the world. The first identification of HIV-2 occurred in 1985 in Senegal for microbiologist Suleiman Membo and his collaborators. Many test kits for HIV-1 will also automatically detect HIV-2. There are 8 known HIV-2 groups designated A to H. Of these, only groups A and B are pandemic. Group A is found mainly in West Africa, but has also spread to Angola, Mozambique, Brazil, India, Europe, and the US. Despite the presence of HIV-2, lowly group B is mainly confined to West Africa. So another most important part of our today's class is pathophysiology of HIV infection. It is a bit difficult for everyone to understand. I will try my best to keep it simple and less complicated as much as I can. But for some people, the virology is a dry subject. So maybe some of you uh, will struggle with understanding this, but I will try to make it palatable and easy for all of you. So HIV, as we already know, it's a part of retroviroidae family, infects CD4 cells and macrophages by binding to CD4 receptors and chemokine receptors of the macrophages, leading to fusion and viral entry. After entry, the intact viral capsid travels to the nucleus where reverse transcription, facilitated by reverse transcriptase, converts viral RNA into DNA, which is then integrated into host DNA by viral integrase. Reverse transcription likely occurs at or near nuclear envelope, although its exact time and location remain under investigation. High mutation rates during this process due to the error-prone reverse transcription contribute to HIV's genetic diversity, resistance to antiretroviral therapy. Within days of exposure, HIV disseminates from mucosal sites to lymph nodes and plasma of the person which is infected with HIV. The initial phase involves rapid viral replication and CD4 T cell depletion and destruction, followed by decline in viremia due to CD8 plus T cell response. However, immune control is incomplete. HIV persists due to incomplete, inadequate humoral immunity, especially B cell follicles, and low levels of follicular CD8 plus T cells. CD8 plus T cells are basically cytotoxic T cells, contributing to chronic infection even under antiretroviral therapy. So I will explain this diagram. So first of all, HIV virus comes and this attached through the GP120. This uses GP120 surface protein and attaches with the CD4 receptor of the host cell, which is a CD4 T lymphocyte. Then the HIV gets attached to the wall of the host cell. Then HIV RNA, reverse transcriptase, integrase, and other viral proteins enter the host cell. After it enters the host cell, it dissolves in the host cells, and viral RNA, reverse transcriptase enzyme, and all other essential proteins are free floating in the cytoplasm. Then this enzyme and this viral RNA enters the nucleus. Then viral RNA enters the nucleus via an enzyme called integrase. This integrase then integrates the viral RNA into the host DNA, which is present in the nucleus. Then this viral DNA becomes a part of host DNA. Then host DNA confuses this viral DNA as the part of its own body, and then as the DNA replicates, the viral RNA also starts getting formed due to host getting confused and not knowing that this viral RNA has been uh, integrated in the form of DNA into the host DNA. Then host DNA gives orders for the formation of new viral RNA using that integrated viral DNA, because that integrated viral DNA gives orders to the host cell's system that now create RNA copies of this DNA. And the host cell, as it does not know that this virus has integrated into DNA, keeps creating too many copies of the viral RNA, and then this new viral RNA becomes out of nucleus. New viral RNAs uses genomic RNA and to make viral proteins. Then viral proteins assemble, and then this assembly creates a new virus, and then new viral RNA and proteins move to the cell surface, and a new immature HIV forms. And then virus, after releasing the viral protease, cleaves mature infectious virus. And this cycle goes on and on and on. And the host cell, once the body becomes to know that it is infected with HIV, the host start killing themselves, or other cells of the body such as natural killer cells or cytotoxic T cells start killing these host cells. So as these host cells are helper T lymphocytes, these helper T lymphocytes start getting depleted in the body. So the body, in order to get rid of the virus, start killing the cells which are infected with the virus. And as the virus has infected almost all of the CD4 T lymphocytes, the body starts killing these CD4 T lymphocytes. And as these are helper T lymphocytes, so along with the bad, the good is also dying. So, so the virus is getting kicked out, but majority of the CD4 T lymphocytes also die in the process. And as these are helper T lymphocytes, they modulate our natural immune responses to a variety of other infectious diseases as well. So as they deplete, we become prone to other infections as well. So I hope I simplified it and made it palatable for you. I know some of you people will find it a bit difficult to understand, but this is the basic concept of majority of viruses that attack our body. So HIV is also part of such retroviridae family, because this is the reverse transcriptase enzyme is a devastating enzyme, and this reverse transcriptase integrates viral RNA into our DNA, makes viral RNA in the form of host DNA. Host DNA integrates that viral RNA, and host DNA fools the viral DNA as its own, and then the viral DNA masking itself in between the host DNA gives orders for the production of new viral RNA and new viruses eventually. One of the hallmark features of HIV infections is the progressive loss of CD4 T lymphocytes, which are crucial for the immune system. Most CD4 T lymphocytes, more than 95%, die without producing new viruses. These are resting in inactive CD4 T lymphocytes, not ready to support full HIV replication. So majority of the cells hesitate, resist, they die without producing new viruses because they are resting T lymphocytes. They are only present in our body to become active when there are infections in our body. So these resting T lymphocytes in many reticuloendothelial organs of our body, such as liver, spleen, bone marrow, etc. So these areas and lymph nodes, intestinal lymph nodes especially. So these areas where these resting T lymphocytes are, they start getting died, and they start getting dead. So what happens that there is a programmed cell death called apoptosis. So these cells start killing themselves, or other body systems start killing these cells when they are infected with the virus. HIV enters these cells but cannot complete its life cycle. This is called abortive infection. What happens in our abortive infection? HIV starts converting its RNA to DNA, but the process stalls. Incomplete HIV DNA builds up in the cytoplasm as the cell instead of entering the nucleus. Then cell detects this abnormal DNA using a sensor called IFI16. IFI16 triggers an immune response inside the cell. IFI16 activates a structure called inflammasome, which turns on caspase 1. This caspase 1 induces a very inflammatory and destructive form of cell death called pyroptosis. This not only kills the infected cell but also releases the inflammatory signals in surrounding tissues that can harm neighboring cells as well. So basically, a virus infected cell kills itself through a pathway triggered by a protein, a sensor called IFI16. So this sensor detects abnormal DNA. So when it detects viral DNA present in the host cell, it creates a pathway which is caspase 1 pathway, which creates inflammasomes, and they kill the cell itself. So basically, cells commit suicide. Meanwhile, only 5% of the CD4 T lymphocytes are activated enough to support full HIV replication. These cells do produce new virus and die through a different, cleaner process called apoptosis or programmed cell death. But after replicating too many copies of virus, the viremia or the viral load of the body increases, and these 5% active T lymphocytes also start getting died. So these are the other cells which are also infected with HIV as well. So HIV not only attacks T lymphocytes, it also attacks monocytes, liver macrophages, bone marrow progenitor cells, genital tract macrophages, intestinal macrophages, splenic macrophages, alveolar and intestinal macrophages, and microglia and brain macrophages as well. So HIV not only affects or attacks lymphocytes, it also attacks macrophages as well. Macrophages are basically the basic immune cells which are the basic policeman cells which are stationed in all of the organs of the body. Whenever an infectious agent enters that organ, for example lung infection or liver infection, these macrophages kill those infectious agents. But apart from damaging T lymphocytes, helper T lymphocytes, the HIV also attacks these macrophages as well. We are getting short of time. I am going into too many details. That is why I had to divide this HIV into part A and part B as well. So cells affected with viruses are lymphoreticular system cells, which are helper T lymphocytes, macrophages, and monocytes, and certain endothelial cells as well. And the CNS cells are also affected, such as microglia of the brain, astrocytes of the brain, oligodendrocytes of the brain, neurons of the brain. I won't go into the details of what microglia are, what astrocytes are, what oligodendrocytes are, because it's related to the neurology and brain, and it will go out of the scope of this lecture. But CNS also gets affected with HIV infection. That you people should know. The signs and symptoms of HIV infection. The stages of HIV infections are acute infection, also known as primary infection, then latency period or chronic infection, and then AIDS. So AIDS is the final stage of HIV infection. Not everybody infected with HIV has progressed to AIDS by the time that person gets detected to have HIV infection. For example, if a patient, you have come to know that the person is infected with HIV, maybe they are in acute phase. Maybe they have contracted the virus just 2 months ago and they are having acute infection symptoms. Or maybe they are in the latency period, or maybe they have developed AIDS after 2 or 3 years of continuous infection because the body can't kill the virus at all. It can only control the viremia, it can only control the viral load, but the body cannot completely cure itself of the HIV infection. So acute infection lasts for several weeks to months and may include symptoms such as fever, swollen lymph nodes, inflammation of the throat, rashes, muscle pains, malaise in mouth and esophageal sores. So basically, the person doesn't know what kind of illness is that. They are sick for several weeks. For example, if a person is having flu, it lasts up to maximum of 10 days. Mostly flu symptoms subside within 5 days, but it can last up to 10 days. But these symptoms, fever, swollen lymph nodes, inflammation of the throat, rashes all over the skin, muscle pains, cramps, malaise, mouth and esophageal sores out of nowhere have developed and they're persisting for several weeks, then the person is having acute infection. Then the latency stage involves few or no symptoms and can last anywhere from 2 weeks to 20 years and or more depending on the individual. AIDS, the final stage of HIV infection. Remember it, AIDS is the final stage of HIV infection. AIDS is the final stage of HIV infection. Is defined by low CD4 T lymphocytes, fewer than 200 per microliter. Various opportunities, infections, cancers, and other conditions also occur in this state. So when a person has eventually progressed to AIDS, they are having many opportunistic infections which are not present in healthy individuals. So fever and chills are there, headaches and mood swings are there, sore throat, swollen lymph nodes, and mouth ulcer are there for weeks and they're not going anywhere, and the person is having high risk behavior as well, you should think about HIV. Muscle and fatigues, nausea, vomiting, loss of appetite, joint pains, in women, changes in menstruation, lower belly pain, and vaginal yeast infections, later stages of infection, and clamminess and rashes and blueness of the skin, high heart rate and low blood pressure, pneumonia, cough with sputum, shortness of breath and chest. And so basically, there are a variety of symptoms, and the patient is showing these symptoms out of nowhere, previously healthy person, and these are persisting, then you should suspect that there is something wrong. Acute HIV infection, also called primary HIV infection or acute seroconversion syndrome, is the first stage of HIV occurring days to weeks after exposure and before the long asymptomatic latency phase. Around 50 to 90% of infected will develop flu-like or mononucleosis-like symptoms, such as common symptoms, which are fever, sore throat, swollen lymph nodes, rash. We are already discussing details. And less common symptoms are headache, nausea, weight loss, oral or vaginal thrush, night sweats, diarrhea, and neurological issues, genital ulcers, enlarged liver or spleen. Symptoms last an average of 28 days, but may range from a week to a month, or sometimes more than a month as well. These symptoms are often non-specific and misdiagnosed as common viral illnesses as well, because there are many illnesses, many viral illnesses which show these symptoms. Common symptoms: fever, sore throat, swollen lymph nodes, rashes, etc. So there are many illnesses which show these symptoms. So that is why these symptoms are often non-specific and misdiagnosed as common viral illnesses, and we counsel the patient that it is a viral illness, you will get okay, it's not a problem. But if the illness is prolonging more than 2 weeks, it should alert you that it's not a common viral illness now. There is something wrong. Now, the virus is not a common virus because the body gets over it. Body controls the virus. A normally healthy individual controls the virus within 10 days. Influenza virus, herpes simplex, EDC, respiratory syncytial virus. So these are common viruses which cause respiratory infections and some other infections as well. Body comes over these viruses maximum of 2 weeks. But if these common symptoms, the less common symptoms, are more than 2 weeks, it should alert you that the virus is something serious. It's not a common virus. Despite this, recognizing acute HIV is important because patients are highly infectious during this period. So when acute infection is going on, patients are highly infectious. They are spreading virus on steroids, like they are spreading virus everywhere. Their all of their body fluids are secreting virus in bulk. So they are highly infectious. That is why recognizing acute HIV is important. Then latency phase or chronic HIV infection after the immune system lowers the viral load, the HIV enters the latency or chronic phase, which can last from 2 weeks to 10 years. During this stage, HIV remains active in lymph nodes, causing persistent lymphadenopathy. The virus accumulates in the follicular dendritic cells and nearby CD4 positive T cell rich tissues. The CD4 positive T cells carry most of the proviral or latent virus. People in this phase are still infectious even if symptoms are absent because the body has somehow controlled. Majority of CD4 cells have already destroyed. Some sort of immune response has generated and the body has become used to the state of getting infected with virus. So acute symptoms have subsided and patient has not yet developed AIDS, is present in between the acute infection and AIDS, but patient is infectious. Patient is carrying the virus inside its body fluids. So even if symptoms are absent, patient is still spreading the infection. Some rare individuals maintain healthy CD4 counts without treatment. Some very healthy and very athletic and very rich um, diet taking people can control the virus and subsequently do not develop AIDS for up to 10 to 15 years, but eventually they can develop. HIV controllers, these people are called HIV controllers or long-term non-progressives, stable CD4 counts but may have detectable viral load. And then elite controllers or suppressors maintain both high CD4 counts and undetectable viral loads without antiretrovirals as well. So these people are special because they control the virus on their own without any antiretroviral therapy. Now AIDS. Symptoms of AIDS are primarily the result of conditions that do not normally develop in individuals with healthy immune system. Most of these conditions are opportunistic infections caused by those bacteria which do not harm healthy individuals, caused by those viruses which do not cause infections in healthy individuals, caused by fungi which do not cause infections in healthy individuals, and parasites that are normally controlled by the elements of the immune system that HIV damages. These infections affect nearly every organ system. A declining CD4 CD8 ratio is predictive of the progression of HIV to AIDS. Many systems get involved with the progression of AIDS, such as pulmonary, GIT, and neurological infections, along with many tumors as well. So I haven't gone into details of these organ systems, but maybe I will go into the details of some organ systems involved in our part B of the lecture series because I have to end it now. So pneumocystis pneumonia, tuberculosis in pulmonary system, esophagitis due to candida or herpes simplex virus or CMV, all of these candida, herpes simplex virus or cytomegalovirus are not that much infectious that they can damage the esophagus of healthy individuals, but they damage the esophagus of a person who has progressed to AIDS. Then chronic diarrhea is there. Then toxoplasmosis and cryptococcal meningitis develop in AIDS people. PML viruses, then HIV associated dementia and AIDS related mania. All of these things are present in people who have developed AIDS. Then there are some tumors such as Kaposi sarcoma. Then there are some lymphomas, cervical cancer, and other cancers as well, such as Hodgkin's disease and non-Hodgkin disease. And then there are some opportunistic infections. So all of these things are the hallmarks of AIDS. I will touch them briefly in part B, but as these are extremely long topics, so I will not be able to go into details of these illnesses, as then this thing will divert us from the main topic. So WHO staging system of HIV infection, I have added it. So WHO system uses the following categories. They call it the primary HIV infection, may be either asymptomatic or associated with acute retroviral syndrome, which is stage 1 HIV infection with asymptomatic person with a CD4 T lymphocyte cell count greater than 500 per microliter of blood and may include generalized lymph node enlargement as well. And what is stage 2? Mild symptoms present, which may include minor mucocutaneous manifestations and recurrent upper respiratory tract infections. So it's basically this staging system is for prediction of conversion of HIV infection into AIDS. So as the stage progresses, the patient goes nearer and nearer to the AIDS. So in stage 1, the patient is far away from AIDS, but in stage 2, the patient is getting more near to the AIDS. There are some recurrent upper respiratory tract infections which are not seen in healthy individuals, and CD4 counts are of less than 500 milliliter. Then there are some advanced symptoms, some advanced diseases which show the immunodeficiency in the individual. In stage 3, which may include unexplained chronic diarrhea for longer than a month, severe bacterial infections, including TB of the lungs, and CD4 count of less than 350 per microliter. Then stage 4 or AIDS, in which we label the person as having AIDS. Severe symptoms, which includes toxoplasmosis of the brain, candidiasis of the esophagus, trachea, bronchi or lungs, Kaposi sarcoma, etc., and a CD4 or helper T lymphocyte count of less than 200 microliters. So stage 4 is when the patient is labeled as having AIDS. But before that, the patient is not labeled as having AIDS, but is moving towards AIDS in every single step. Have a nice day. Thank you. As I already knew, this is a very vast topic, so I had to divide even my HIV class into two parts as well, so that I can do justice with my topic. Any questions, please?
The questions are already coming in. Ismail, you're first. There are many questions in chat too.
Yeah, I know. This is a very interesting topic. Infectious disease. We will have to spare some time for the questions at the end. I tried my best to end it before 1 hour, but as you know, the topic demands too much elaboration. So even
Mhm.
I divided the topic into two parts. Still, I couldn't manage because there is a sea of knowledge that I wanted to deliver. I'm sorry for that. I wanted to end it in 50 minutes or so, but I couldn't. Okay, move on to the questions. We are short of time already.
Yes, Ismail.
Yeah, thank you, sir. Good morning, sir. Yeah, good morning, Dr.
It's
Lambert.
evening
Yeah,
here.
yeah,
Uh,
good evening. Good morning, everyone. Yeah, actually, I have a lot of, yeah.
from different
Thank you,
parts
sir.
of the world, so it's fine.
Okay, sir. Actually, I have a lot of questions on the prevention and the
Go to the
management.
most
But
important ones. We
since,
will go to the most
yeah,
important
but
ones.
don't
Your questions,
worry. But
I
since you say you
I
will
like your
not,
questions,
uh,
but there are too many
yeah,
people waiting.
okay. All right. You mean, can I go ahead with the question?
Yeah,
Can I go ahead with the question? Because the question is
yeah,
on
you can ahead with the question, but
prevention.
I
Okay.
want just most important ones.
All right, good. Let me go ahead with the question then. Okay. Actually, the question is this: what gaps exist in the research, current research in HIV/AIDS that could inform more effective prevention and treatment strategies?
Can you please repeat the question because your
Uh,
voice was
okay.
breaking down? Sorry.
Okay. Doctor, hello? Hello?
I'm listening. I'm listening.
Yeah.
Your voice just broke down on my end.
Actually, the question is on prevention. I wanted to skip it. So by giving you another question, or
No,
by
no, no,
asking
no, no.
another question, okay, can I ask the
Save your
question?
question for our next class. Save your question for our next class.
All right.
Because
All right.
prevention is this much
Okay.
important
Yeah.
that I had to
Yeah.
divide this topic into two parts. I didn't
Yeah. So,
want to do it, but the prevention of HIV is this much important that I had to divide this topic. So save the prevention questions for the
all
next
right.
class.
So
Go
this
ahead
was
with
what I
another
was
question.
saying. Yeah. Yeah. Let me ask the question now. Another question is this: how does HIV/AIDS affect economic development in affected countries?
Yeah,
Yeah.
it does. It does affect economic development because the healthcare burden is too much. Uh, just like cancer, just like cancer, there was a research done in UK, and they were studying the cancer burden of the UK, and it was like $60 billion. So basically, any devastating illness, its testing, its research, all of the laboratory equipments, all of the institutions, all of the antibiotics and antiviral therapies being done for the opportunistic infections, critical care wards, ICUs, intensive care units, all of the doctors, all of the nurses, all of the paramedics, whole institutions. So everything you have to do because of one major illness, just like cancer or AIDS. So you have to build a public health program worth billions and billions of dollars just to fight off this menace, just to fight off this disease. So definitely, if you want to develop something else, but there is a disease which demands 10 or 15 billion dollars of a country whose whole GDP is 100 billion dollars, what will you do? You will get that 15 billion dollar of the total $100 billion GDP, and you will invest it just in eradication of that disease and not in some social empowerment scheme, not in some other uh, good scheme, not in developing roads, not in developing bridges, not in providing electricity, not in providing healthy, safe water, etc., etc. So basically, that disease already a poor country due to the colonial past, already a poor country, and then there is a disease which is a sickening menace, and you have to divert already short in supply funds for the development for the prevention or treatment or management of that disease. So it is devastating for developing countries. Thank you.